when spinal surgery makes sense and when it doesn't. I'm going to tell you some things here that may be eye-opening and are facts based on research that you probably have never heard before. Hey folks, this is Dr. Jeff Williams right here in beautiful Amarillo, Texas, coming to you with a great one this week that you're probably going to want to forward and share with your family and friends because it can be that life-changing for some people. Here at Creekstone Integrated Care, for example, here in Amarillo, I see patients pretty much every day that are here to get out of pain. That's normal. A lot of us have pain, but many of them are desperately trying to avoid surgery on top of that. Many times, they've been told that surgery is eventually gonna happen whether they want it to or not. Like the idea, don't like the idea, you're still getting surgery eventually. And how frustrating that must be. Not only can that be frustrating, but it can be absolutely frightening as well. Before diving in, I want to make something real clear here. I'm not against surgery or surgeons. I'm definitely not against surgery for the right patient. Sometimes it's not only necessary, but it's an emergency. Surgeons, for the most part, are highly intelligent and very capable human beings, as most of you know and understand. Thank God for these men and women, right? What would we do without them? They can absolutely save lives, and they do save lives every day. I am, however, against surgery for the wrong patient. Certainly, when research shows us very clearly that many of the problems that are fixed are not necessarily out of the ordinary. Most of us have these problems. They just don't bother us. And in the end, those things may not even be what is actually the source of the pain in the first place. We know this. And this is, we have been shown through research that less traditional practitioners, like chiropractors and physical therapists, for example, are highly effective in treating these patients safely, conservatively, non-invasively, and without pharmacological means. No opioids, right? None of the hard stuff. So I am 100% against surgery in those patients that can be helped otherwise. So let me throw a hopeful statistic at you here. Out of the approximately 56 million sufferers of back pain, only about 5% of those actually need surgery. That's an impressive stat, folks. Only 5%. There is another research paper by Keeney et al. That came out probably in the last 5 to 10 years that compared back pain sufferers that used surgeons as their very first stop in the healthcare system. It compared those patients to those pain sufferers that used chiropractors as their very first stop in the healthcare system. And it was amazing. It showed that those seeking care with a surgeon first had surgery 42.7% of the time. Wow! That is a huge number, folks. 42.7%. But get this. For those visiting doctors of chiropractic first, they only had surgery 1.5% of the time. That's huge too, wouldn't you say? They say if you only have a hammer, everything looks like a nail, right? Now, this paper proved that if you go to a surgeon, there's a high likelihood that you're going to get surgery. But guidelines and more current research is showing that the vast majority of the time, back and neck pain sufferers do not need surgery. Research from this year by Harris et al., just this year, suggests that the problem with spinal surgery is that surgeons look at pain as a purely mechanistic issue. Now, what does that mean? Well, it means that if they can just cut it out, we'll cut out just this bulging part, or we'll cut out just this arthritic spur here, then the pain should go away and everyone should be happy, right? Well, that sort of mentality completely discounts what is termed yellow flags and the biopsychosocial aspect that helps make up the pain experience. For example, when a patient is in what is called chronic pain syndrome, and they have surgery where everything goes perfectly during the surgery, everything goes as planned. That patient, they're in chronic pain syndrome, and now they still have a 60% chance of developing pain at the new site of surgery. And that's because part of the pain experience that the brain takes part in is not being treated. And you got to know, without the brain, there is no pain. And in a significant portion of patients, pain does not just exist at the place where the patient points to their pain. If they say, oh, my wrist hurts, and it's hurt for 10 years, not all of that pain exists right there in that wrist. I know you might not understand what I'm saying, but we're going to get there. The easiest way to demonstrate this is in the case of phantom limb pain. For those that are unaware of phantom limb pain, it's when an amputee has an arm chopped off, for example, right? An amputee, they still can experience pain in a limb that has been amputated and it's completely gone now. So how can you still feel pain in something that no longer exists or is even attached to your body? It's possible because for chronic pain sufferers, part of the pain lives in the brain, and the pain experience, it's made up of various factors, including the patient's beliefs about their condition and their beliefs about their ability to recover, the patient's level of sensitization in their central nervous system, having an excited central nervous system, maybe what they've been told by other practitioners, even their confidence in their treatment going forward. And these are just a few things that all combine to make up a person's chronic pain experience. So this is the very essence of the biopsychosocial aspect of pain, and it's summarized fairly easily and briefly. Trust me, it's a very complex topic. But for a large number of patients, you can't simply go in and cut pain out and then sew the patient back up and then they're good. Not for chronic pain patients all the time. And it just doesn't work that way, which is why so many back and neck surgeries have to be repeated several times. A lot of you are nodding your head with me right now. So what about the surgeries themselves? What do we know about that aspect of spinal surgery? Well, fortunately, the research that we mentioned by Harris and his colleagues, it gives us some clarity in regards to chronic pain patients and common surgical interventions. It turns out that the most common surgeries for musculoskeletal conditions in chronic pain patients have very little real solid randomized controlled trials behind them to support them. There's little to no research comparing the surgical procedures to patients that didn't have the surgery at all. In fact, of the 6,735 studies done on these most common surgeries for chronic pain, 6,735, only 64 of them compared the surgery to not having surgery at all. That's less than 1%. 1%. And here's the kicker though, the real kicker. Of those 64 that actually did make the comparison between surgery versus not having surgery, only 9 of those papers were actually favorable to having the surgery. The enormous majority of papers did not favor having the surgery over not having the surgery. To round this discussion out a little bit, none of the studies using patient blinding for the procedure found it to be significantly better than not having the surgery at all. None of them. So why are we having all these spinal surgeries, right? So let's get on to the topic here. When is surgery not okay? Okay, well, let's talk about that first, and then we'll get to when it is okay, okay? Of course, these are generalities here, and they do not constitute medical advice. So if you got issues and you got specific questions, go to your doctor and get them answered. But in general, the vast majority of non-complicated neuromusculoskeletal pain can and should be treated by an evidence-based, patient-centered chiropractor that is experienced in utilizing a wide array of modalities to achieve a positive effect. That's a lot of big words, but basically go to a chiropractor that is using a whole bunch of stuff to get you better. Things like spinal manipulative therapy, exercise, soft tissue treatment like massage or manual therapy, stuff like that. Maybe acupuncture. Lots of tools are in a chiropractor's toolbox if he's evidence-based and patient-centered. Now, when there is no decrease in muscle function, reflexes, or sensory information from one side of the body to the other, if there's no decrease or difference in the function of those three things, then there's usually no need for surgery. And trust me, I know this here. It is easy for someone in zero pain to say this. I understand that. So this may be an unpopular opinion, but in general, pain is not a reason for surgery. And I want to say that again. Pain is not a reason for surgery. Remember, 56 million sufferers of pain, only 5% actually need surgery. When your reflex, sensory, and muscle function are even from one side to the other, most findings on MRIs like disc herniations, disc degeneration, arthritis, and things like that, they're not reasons for surgery. They are reasons for treatment with a conservative practitioner that has experience in getting these types of patients out of pain. Now keep in mind that sciatica or pain into a leg or something like that is not a reason for surgery initially. We have been very successful in getting symptoms into limbs to resolve if we're given the time and given the chance. Also, beware of new treatments, okay? Many times patients are desperate to get out of pain and they're going to try any quick fix available up to and including new and unproven techniques. As I have shown, even the established techniques are not typically thoroughly vetted. In fact, almost all of them are not. So you can be fairly confident that new procedures are also not well validated. Now, when does surgery actually make sense? When is surgery okay? Well, the most obvious case where surgery is required is when there is trauma, like a car wreck, a severe fall, or something of that sort. Can most certainly be a reason for surgical intervention, no doubt about it. In addition to trauma, another big reason for surgery could be a change in bowel or bladder function, or if there's numbness or tingling in the areas of the body up and underneath that would contact a saddle when you set up on one. That's called cauda equina syndrome. That's surgical, and that's an emergency, so get to the hospital. According to a global expert, Dr. Stuart McGill, PhD, he's amazing, guys. You should consider surgery when the pain has been unrelenting and severe for a substantial period of time. But he says that patients that have been in pain for only 3 weeks or so, and then they have surgery, that those patients have been some of the most disabled post-surgical cases he's ever seen before. And he also says to discuss the pain with the surgeon. What is the pain generator? Can it actually be cut out? And if several tissues are involved, you need to know that the chances of success go down for sure. If there's damage at several spinal levels, well, the chance of success drops substantially from there as well. So you have to consider things like that. In short, you must exhaust conservative treatment first before you even consider surgical intervention. And that's not simply the opinion of a chiropractor here that stands to gain financially if all the potential surgical patients come see him. No, that is the opinion of the American College of Physicians. In their report by Qasim et al. In 2017, they laid out recommendations for treatment of back pain, both chronic and short-lived pain. And they are as follows. The first recommendation, clinicians and patients should select non-pharmacologic treatment with things such as spinal manipulation, massage, heat, acupuncture, and potentially non-steroidal anti-inflammatory. The second line recommendation for patients with chronic, long-standing back pain, again, seek non-pharmacologic treatment with spinal manipulation, exercise, acupuncture, cognitive therapy to treat the biopsychosocial aspect we've been talking about, Tai Chi, yoga, low-level laser. We have so much of that here at Creekstone. And then the third level of recommendations say that for those that don't respond to non-pharmacologic treatment, maybe use tramadol or duloxetine may be appropriate. Opioids are only an option in patients who have failed all recommended treatments. Obviously, the last line therapies will be things like your epidural steroid injections and surgical intervention. Those are last lines after everything else has been failed and tried extensively and exhausted and failed. Then you look at epidural steroid injections and surgical intervention. But too many practitioners are still trying to keep this dynamic completely flipped upside down in an archaic, dogmatic attempt at maintaining the status quo and maintaining a static income, right? So some final thoughts on spinal surgery to wrap this video up here. One of the worst sayings known to man is, "We've just always done it this way." And recall, if all you have or all you know is the hammer, everything looks like a nail, doesn't it? Well, the most disappointing part of it all is that chiropractors only see about 10% of the population on average, give or take. So think of all the people we could help, all of the patients that didn't know they should have been given other options that research has proved are highly effective options. What if they were just told that? I mean, honestly, you can help me here. You can help other people by sharing this video with others. Share with them right now so that someone you love that might be scheduled for surgery tomorrow realizes that there may be another way. Because honestly, most of the time, there is another way. Aha moments are powerful, and this video may just be that for someone you truly care about. So do us and do your network of people a favor and pass this information along to them. Maybe we can start to turn this tide around. Again, this is Dr. Jeff Williams here in Amarillo, Texas. If you're watching on YouTube, hit that subscribe button so that you don't miss anything important next week or the week after. If you're watching on Facebook, share this video just like we were talking. It really could make a difference for somebody important to you. If you live here in Amarillo or you're passing through and you need our help, make sure you call our office at 806-355-3000 and let's get you a time set up. We'll see you here next week, folks. God bless.